Here we are with Dave Renfrew. Thank you for joining us, mate.
Thanks for having me, man. As always.
We've been asking these questions a lot in the chat, these questions of each other, and I shot you like 5 or 6 questions, and we thought we'd talk about them.
There are also questions that I ask myself constantly, so it's good to have someone else in the conversation.
I had another random one that came to me this morning that I'm going to drop on you.
All right.
And I guess that let's go with the purpose or the outcome is like, we feel in these questions is the context and the word nuance, which has been thrown around, where if there's a discussion around it, it might help younger practitioners see the gray and potentially not the black and white. And if we're still asking ourselves these questions, that's probably a good sign as well.
Yep. And I think it's much easier to talk about it. Even this may not be literally face to face, but it's so much easier to have a conversation about it than a binary online. It's not a discussion. It's like here is point A, here is point B. There is no gray in those discussions. So I think it's also a environmental constraint. Social media just doesn't allow you to talk like this, like with your hands like this.
Yeah. That's good. I like it. And also, wherever we post this, but if you're an iReview and you're watching or listening, go and follow Dave at Future Health Network, because he's doing great things. And what I like about your work, mate, it's not just evidence slinging and paper throwing. I feel like you have the conversation in between, which I really enjoy that. And there's probably a time and place for both, but I think more discussions are helpful. So the first question is, do we treat acute and chronic differently? And that might even be to how we approach it, to the words we use, to our assessment, to our rebooking.
And we're talking about pain as opposed to broken legs, right?
Yeah.
So, and this is a great example. So they are different, but does that mean we have to treat them differently? I don't know. I don't think we should treat the people differently. So, and that's always tricky when you go. So I laughed with Kelly Physio and my team. We were chatting about my diary, and I just see a little note on Clinico popped up in capitals, and I think that was probably a mistake. But 30 years of pain, and I just laughed and went, "Oh, great! This should be fun."
Very alarming.
But outside of those little jokes that we make, like, I really don't think we should treat people differently. And I think that's one thing with chronic pain people, that they're sick of being treated differently. They're sick of being treated like crazy people. So listen to their problem. It's just that their problem's probably bigger, right? Like if you've had pain for a day, that's probably different than if you've had pain for 1,000 days, right? So the story's longer. There's more twists and turns. There's more layers to it. There's probably more shit experiences. So it is different. There's no doubt it's different, but I don't think we should treat the person differently. And this is where you'll probably ask me about this later, where my biases are. But I always think that a lot of chronic pain is probably avoidable / is probably made worse by a lot of healthcare. So I'm tending to come at it from a point that it's not their fault. There's probably something in that story that made it worse when they asked someone for help. So it's definitely different, but I don't think you should approach it differently.
If we broke it down into like assessment or communication, so I'm thinking of like the Louis Gifford questions, or even what would be a good outcome for you today with our time together, or what are your expectations from today? Would you ask those questions of an acute patient who just sprained their ankle versus a chronic patient? And do you frame them differently?
I think that if you think of it like layers, so it's everything all the time, right? So I say this to my team and people: when someone snaps their ACL, you're going to talk to them about the effect of that on their life. So just because someone doesn't have an acute pathological problem, it doesn't mean you're not going to talk about the effect it has on their life. Similarly, if someone's just sprained their ankle, are you going to talk about, if they're stressed at work? It's like, what do you mean? Like, I just fell over. That's probably why I've sprained my ankle. So you can't have recipes that you follow, but but at the same time, you probably do have to have a bit of a framework where you're approaching these things. And I think the more complicated a problem, the more likely you're going to have to go into the depths of these layers and get more out of more information from them, so you understand it, and so you can show that you understand it a little bit better. So you're probably the person with the 30 years of pain, you're probably asking them more questions, and probably second or third level questions. It's like, so what do you want from me? Less pain. Of course you do. You've had pain for 30 years. But if you had less pain, what would you do? Or what is that? What have you missed out on? What do you really want to get back to? It doesn't mean that the person with the ankle sprain doesn't want to get back to stuff, but they can probably see that it's going to be easier. Whereas the person that's been in there for 30 years, part of the thing is they can't see their way out. They just don't know how to get out. And they're probably sick of asking you, like, that you might be the fifth, sixth person they've asked for help. And they've just like, fuck, this guy's going to, you better be the one. Otherwise I'm just going to, and you can see that in them. So I reckon it's more that you may have to just go into that stuff deeper and for longer with a more complex problem.
The danger here, I'm challenging myself on this too, is that you may assume that the acute ankle sprain doesn't need that. And that is potentially, who knows, the reason for chronic pain and this epidemic that we're seeing, because that acute ankle sprain, you might not ask second and third layer questions. They might have a bunch of beliefs. They might have a family member that had their foot chopped off at the shin, and you don't ask those questions, and then it can all fall to pieces. So challenging my bias, those questions probably need to be asked for everyone, but you'd hear it in the story, you'd use your clinical judgment, or maybe you ask them and it's a quicker, snappier response, and you're like, okay, they don't need to hear more about that. What about the directive versus collaborative? If that's a treatment expression, do you see that as a spectrum? Because that was my bias of, I think if they're acute, I tend to want to be a bit more directive. Like, it doesn't seem like you're holding any poor beliefs about an ankle sprain. You've done it before. You'll get better in 3 or 4 weeks. I'll be a bit more directive. And then with someone that's had 30 years of pain and it's in capitals in the diary, I'm probably holding a little bit more space. Do you see it that way, or is it the same danger if we don't ask those questions of the acute patient?
Yes to both. I think when something's a bit more acute, people are probably, and again, we're in the gray here, so you'll have an example of where I'm wrong, but probably they'll be more like, what do I do? You tell me, you're the expert. But and particularly more so, I think with tissue injury. So if you've got, say, the acute back pain person, I won't say all of them, but most of them are like, you tell me and I'll do it, which is why lots of people with very severe pain end up getting surgery, because they're like, do something about it. This is shit.
Yeah.
Go and see someone, get a scan, I don't care, just do something to it. And they end up having surgery made perhaps unnecessarily. So I think they're prone to, you tell me what to do because this is shit and I want out right now. Whereas someone who has had it for a long time, by definition, they're the expert in it, because no one knows what that's like apart from them. They still may want you to say, you tell me what to do, but I think by definition at that point, particularly having stereotypically seen 5 or 6 people, I would be more likely to say that to a person like that. But also, I think the reason I think that's useful is because they're less likely to have heard it in the past. So I think it's about being comfortable with both, or either, or everything in the middle, and trying to gauge the correct response based off who's in front of you. And that's the tricky bit, right? So, and sometimes you'll be wrong. Sometimes you'll say, well, what do you think we should do? And they say, well, you freaking tell me, you dickhead, that you're the expert. Shit. Okay, well, I think we should do this, So that's the really hard thing for newer clinicians to get comfortable with, is just the wide range of things you could say and do, and the wide range of people that you'll see, and picking which one to go with, and hoping that you've got the right one.
What do you think of the spectrum analogy? literally, if I could show you my brain, I have a patient in front of me, and there's like hands on, hands off, and it's like a sliding dot. And then there's directive and collaborative and a sliding dot. And then there's psychosocial factors and a sliding dot. And then there's like the big biomechanical factors and a slide. And I'm adjusting that with everything they say, even though it is all things all the time. How do you feel about the spectrum analogy? Is that something that works, or does that break down?
Well, I think that's a great idea, and I think that's a lot of things. Like even I've gone through a thing with my team about imaging and not imaging. So the reason it's really good idea is that when you've got decisions that you can make, those decisions are often binary. So whether you get imaging or don't get imaging is a binary decision. Whether you direct someone or collaborate is a binary thought. But what people forget is the spectrum. So they misrepresent the spectrum as the binary choice. So it's not, by definition, on a spectrum, you have to have this end and this end. But the idea is that you are somewhere between those ends. You are not at one or the other. And that's the thing, I think, that gets confused with any sort of discussion, particularly online, because it creates that the whole structure is you talk, I talk, you talk, I talk. So it creates it and people are unaware of that. But the thing is that the spectrum is where pretty much everything lands, and you've got all these things that weigh up, your decision making. And the point is too, I think, for younger clinicians, that you pick a starting point, but you know that you might be wrong and you can adjust. Whereas if you've gone, it's this, not this, you're either right or you're wrong. And if you're right, then great, but you might have been a fluke. And if you're wrong, then you're screwed. So if you're in this gray area in the middle, you can adjust more easily. So being uncertain is helpful, because you're just going to be wrong. You are going to be wrong. It's just going to happen. So, and most people, they don't expect you to have all the answers. So presenting it as a spectrum is probably accurate, because that's probably the way most things are, right?
I like that. And there's a question that's come across a few times. I want to ask everyone this question, but there's a thought or a thread around someone comes in with pain, and we need to get beyond that because maybe pain isn't their only goal. Maybe pain relief isn't their only goal. You see a lot of people in this space. How true is that for you? Because I've had this pain for 6 to 12 months, and I actually just want to be out of pain. And I know there's second and third level goals, like I'm running less and I'm going to the gym less, but I just want to be out of pain. And the second and third part is just semantics, like obviously. However, at what point do sometimes, as clinicians, do you think we give up on pain relief? And does that ever happen? Like this person, 30 years of pain, is there a chance that you will go into that not wanting to talk too much about pain and giving up on pain relief? And could she actually achieve pain relief? Maybe she's only seen therapists that have said, well, we just need to increase your function. And if we do that, you'll be able to do more things you love. And sometimes your pain decreases when we do that. Any ideas on that or challenges to my thoughts there?
Yeah, I mean, there's a few pain traps wrapped up in that. Like one of them is this: if you get stronger or increase your capacity, that will get rid of your pain. Like that's a bit of that's not true.
Yeah.
And this is where we're talking about spectrums and binary things, but often this is where you have to be happy with paradoxes and have them at the same time. So I'm very upfront with people about my ability to relieve pain, and this is with the manual therapy talking. Like my thing has always been that while manual therapy might be helpful with pain relief, it won't always be pain relieving. So again, if you've set up that if we do this and I will fix your pain and you don't, then you're screwed. So it could, And if it does, then fantastic. And if it could, then why not? Absolutely. But you have to be prepared for if it doesn't, because there's pain's as weird as anything. Of course, there are some people that you're not going to be able to relieve their pain straight away. But then at the same time, I would be pretty optimistic that if given a level playing field, I should be able to help them get out of pain. That makes no sense to think that pain can't change. Of course it can change. There are lots of things that we could get into. Other people have certain conditions and certain aspects that you can't change that maybe mean that they need to learn to live with it. But it's not that if we can't fix it soon, then you have to switch to, all right, you need to learn to put up with this. So I'm probably less optimistic at the start about pain relief, but more optimistic about pain relief as a longer term goal. I only change that long term optimism if there's something there that suggests that I'm probably promising things that I can't sort of back up.
Yeah.
So how predictable is there? And that's the thing with pain, it's so unpredictable. So the language is around it should change. We'll try these things and we'll see if we can. You should expect to get out of it, and that's what we're going to aim for. But it's never definite. So and that can be a tricky thing to talk to someone about when they're in pain and they just want you to get rid of it.
Well, this is where there might be a difference between acute and chronic, in the sense that I think you're more receptive to that message if you've had pain for longer. Because that's been my experience, is that patients that have had pain for that long, they have a good bullshit radar too. And they're like, okay, he's been pretty honest with me. And actually, I haven't heard that before. And maybe the previous 3 clinicians have kind of promised something and it hasn't worked. Whereas the uncertainty to them, in my experience, has been refreshing. Have you found that?
Yeah, for sure. Yeah. And
have you found the opposite?
Yeah, you
as well.
Find the opposite as well. Yeah. So I'm very aware too that when people end up in front of me, I have the luxury. The classic example is they've been to see 2 or 3 people, been unsuccessful. They've been sent to me because apparently I'm the expert. Yeah. And so it's then very easy for me to do better than previous physios have done. It has absolutely nothing to do with me or what I do. It's just how it's been set up for me.
You've got some good placebo in the bank before you start.
Exactly. So I would have to do pretty well to cock that up, So and there's something in that as well that you're with, talking about trying to enhance positive placebo. How can you shape the environment to give you more upside, more potential upside from what you're going to do, So I've just learned to be way more uncertain and transparent about things that I can't predict. But the paradox is then that I'm way more certain about certain people. I'm like, I can definitely help you. This is something that I can help you with. You are in the right place. If this doesn't work, then we will plan A, plan B. I'm way more certain around a lot of the advice, and, you can get back to what you want to do. You're not going to break it. All of these things that I can be way more certain about, even though I'm uncertain about some of these bigger picture things or when or the details or things like that. I zoom in on the things that I can be certain about, that I'm more confident that I can predict.
The fear for me, probably expressed in the post, was that young health professionals, I was just going to say young physios in Sydney, particularly people I've recruited, have come out of university scared to use manual therapy for whatever reasons, judgment, what they've seen online, or maybe just they're reading the evidence that at best it's short term. Do you have any response to that fear? And do you think it's the right place to be?
I think that's the wrong outcome from the discussion. So for context, I went to uni 20 years ago. Yeah. and my university was like manual therapy city, so I got all of it, but I got the if you can't feel this, you're an idiot, you know. So my criticism, criticism of manual therapy is the institution, the old plaid jacket men's club of we're experts and we're awesome and all you guys are idiots. Like that's so when I criticize manual therapy, I'm criticizing that institution of elite you know, experts that aren't very expert in anything other than the fact they think they're experts. But this is always funny. Like, and I'm a good example that as a critic of that, when I say manual therapy, I mean specific interventions based on anecdotal bullshit that I would get lumped in the hands-off thing. And I'm like, well, that's not it at all. Like part of assessing someone is touching them, like, you know, assessing stuff and doing stuff. How do you know if you're not assessing it properly? So do I also then push and pull and do stuff? Yeah, for sure. Like I tell my team that I'm doing sensitivity testing. Like if I do something pretty innocuous and things change, I'm pretty confident that it's not wildly pathological, right? And I can show them that. I'm like, so when I do this, you get more movement. If you were severely broken, that probably wouldn't happen.
Yeah.
And they're like, I can see that. That makes total sense. Cool. Yeah. Here is how you would do that yourself. And then if it keeps working, I can keep doing that for you. And now we can go and do this other cool stuff. So when you're me as a physio with 20 years that gets referrals because I'm apparently an expert, I probably can sit down with someone and have a conversation with them. Not everyone, but some people, and they feel like they've gotten value from me because I've had lots of practice doing that. If you've been working for 3 weeks and you try and talk to someone and convince them that they're okay and you don't need to assess them, you've got no fucking chance. None. Yeah. Like you're just not going to be able to do it because you just haven't had the exposure to those types of communication scenarios enough to do it confidently enough to get people to go, cool, I'm in the right place. But if you assess them and go, look, this feels solid, this is good, look at this when you do that, blah, 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 blah. People experience that and they're like, this person knows what they're talking about because I feel it. And if you're not touching them because you feel that that's what criticizing manual therapy has led to, then I think you've got the wrong outcome from that discussion. And that's not 100, that's not their fault. Like that's where it's probably moved to an area that I think it's moved away from what I was originally talking about. And that's probably been enhanced by lots of different people's own reasons to do that. And that's unfortunate. If that's an outcome of that discussion, then it's created problems for clinicians and then the patients that they're seeing.
I would say most people who appear anti-manual therapy online have pretty much the same lens and the same filter. They're actually against the biomedical approach. They're against passive modalities where patients become dependent. They're against structural narratives. Because when you ask them a little bit further, they're the things that come up. I guess, again, it's a constraint of the platform that you're saying, but potentially something we could do better is whenever we have a stance that might appear that way, we explain the lens that we're coming through, which is what you just did, and maybe explain examples of when you do the opposite to what your thought might be suggesting, which it brought a question up for me. Do you do just like soft tissue work on someone's back that's not part of your assessment, or have you kind of not required for you because you can get those changes in other ways?
I will always, someone that has something that's painful, that's not acutely damaged, or I don't think it's acutely damaged, I will always push on it in some way and move it in some way to see if I can change how it feels for them.
Yeah.
All the time.
Yeah.
Do I think that is like, I don't think of that as like I'm doing a grade 5 C3 amplitude 7 2 on the Richter scale, and I'm not doing that shit.
Yeah.
but I will always push and do stuff and to get an idea of, and to show them. How do you explain sensitivity without showing sensitivity? But I'm never setting it up as this is going to make you feel better. I don't know.
Do you put them on the plinth? Because the way you're describing it, and like we know each other, and there is an interactor effect, maybe that's the wrong word, of like you put someone face down on the bed, it is automatically a different setting. Whereas the picture I'm forming, the way you described it, you'll always poke and prod them. I'm imagining you standing in the gym. Maybe they're not face down, or have I assumed wrongly?
No, they're on the bed. I never put anyone face down.
Yeah.
I put them. I lie them down though. So say it's their back. I'll lie
Yeah.
down. I'll lie them down side on.
Yeah.
And
Spoon them.
I will. Yeah, a big spoon, and just say, "How's that for you?" No, I'm joking. But I'll push around and feel it, and I'll because most people feel like that's what when you're at a physio, that's how you get assessed, right?
Yeah.
Like, how do you know if you don't even touch it?
Yeah.
So, but it also allows, if I'm going into, I like talking, funnily enough, like I talk a lot, but if I'm talking to someone, it sounds like a lecture. If they're lying down and I'm doing stuff and talking, and then like, look, see this, look at this, that feels good, blah, 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 blah. I get to tell them what I'm going to tell them anyway, but in a different context, right? So I'm trying to, how do I make this environment give me the biggest upside that I can to try and positively influence this person? So I will freely admit that the biggest reason that I do that is because at this point in time in human history, people expect that from me when they come to ask me for help.
Yeah.
If they didn't expect that, I wouldn't do it.
That's yeah. So you're meeting expectations, but again, if it's a spectrum, you're meeting expectations in a way that probably optimizes what the evidence says at the moment.
Yep.
I like that. I think most experienced clinicians go that way. It leads me to my next question. And this was a bias that I was challenged on, which I completely agree with, actually. Do we have to have a different approach for new grads as we do people with experience? And in your analogy just then, your example, I think about new grads as still breaking down the consult. Like there's this part, and then we go to the bed in this part, and then we do the exercises in this part, and it's got an order. Whereas what I see experienced clinicians do, and what you just described, we're kind of doing all parts all the time. We're actually doing like a treatment in there, and that was an assessment. And I actually just made you bend over to pick something up, but you didn't realize that. And we're talking. How do we approach that? Do we get new grads to start thinking that way straight away? Or do we give them the structure and slowly nudge them and say, look, you could do it this way too?
I've tried both, and I think it's like learning a musical instrument. Like when you've done it for a while, you can play jazz, but you can't start with jazz.
Yeah.
So you have to learn a certain way.
Yeah.
So I've gone towards, I used to with and I don't know, some that used to work for me might watch this and go, yeah, you fucked that up, Dave. I used to be like, this is out of the matrix, right? This is the brutal reality of planet Earth. Let's go. And some of them were just like, whoa, wait, what the fuck is this? So now I've come to understand, and that I sometimes forget that I have had the luxury of doing this for 20 years. Like you get over time, you go, okay, so maybe not that way, maybe not that way, maybe not that way. And I'm getting them to do that in 3 weeks. It's just never going to happen, right? So I've gone way more structure. Just like a correlation with what we do with a person that's just started, they've just been injured. This is structure. This is what I'm going to get you to do. And then you'll get to here, and it's choose your own adventure. So that depends on the person, but I think more having a framework of how to do things makes learning your craft a little bit easier. Like meta-analysis of your process as you learn your process is fucking hard.
I like that. There's this other question that I want to ask everyone, and it's something to do with specific points on someone's body. So you mentioned before, I'm not going to do like a C3 mob. Let's use the mobbing as an example. And we know that non-specific is similar to specific, no difference in outcomes. How do you describe to a patient or maybe other therapists that when, you know, they push on L2, 3, nothing, they push on 3, 4, nothing, they push on 5, 1, they get something. And then when they get something at a specific spot, how do we explain to the patient and young therapist that even if you felt something at a specific spot, we can still be non-specific? Or when you feel something at a specific spot, do you actually want to do something specific? And am I losing something in translation there?
Well, maybe. I mean, it probably comes down to what you mean by specific. So I think the specificity is specific to that person at that point in time. So when they, and people do this all the time, like they're like, yeah, that's the spot. So the spot doesn't mean that is the, you know, lateral pennate fibers of my blah, 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 my muscle, but that's the spot that means something to them about what they're feeling. So I would do something to that spot because that's what they told me.
And I interpret that as specific, just so we're on the same page. Like you're doing something in a specific spot, but you would say that that's non-specific?
Yeah.
Yeah.
And this is where we get, like, particularly on, you know, so imagine having this conversation written down when we're using the same word, but you think it means one thing and I think it means another thing. No wonder people like it shit hits the fan, right? So is it specific to the structure or is it specific to the person?
Or is it a specific technique you're doing on the specific spot?
No. So that's, I would say all of that is completely non-specific.
Yeah.
So, but it's again, what you like, that's even that, what is that to that person? Like that's a complex level of nociception, sensitization, perception, meaning, and in like environmental contextual factors. So who the fuck knows what that point is? I don't fucking know.
Yeah.
But they're telling me it's important, so I'm listening. That's the thing, right? So if I can then show them that spot changes or maybe could be different or isn't actually the thing, great. That's gold. Because then they're like, oh, okay, so it wasn't actually that important. And I'm like, maybe not. Let's go and do some squats. No, I'm joking.
And we do see specific spots change when we do things in other areas of the body, or just go and load or do an isometric or poke the other side.
Yep.
But also we see those specific spots change when we poke on those specific spots sometimes, or the perception to those specific spots change. In that, is there a patient expectation though? When they say I'm sore there, then my physio did some squats, does something happen there? Do patients expect us to push on the specific spot, or do we just have to ask them?
I don't know. I mean, the other thing is that they could have this specific sore spot and you throw 50 million things at it and it never changes.
That happens too.
That's my other thing with the particularly as people have come out more defending manual techniques and you know, interacting with your hands. This manual therapy as pain relief thing has a limit. It's not always pain relieving. In fact, it's very often not pain relieving for certain things. So I think you just have to be ready, not predict anything you can't predict, and be ready for it gets better, it doesn't change, it gets worse. And you're trying to match what you're doing off the information that you're getting from the person at the time.
How do you end a consult with me if I like some manual therapy on my adductors because it seems to help, but it's short-term pain relief at best? What do you say to someone like me where I'm still in pain, but you know, I want to improve my gym? And you might say, well, we can definitely improve your gym. I'm not sure about the pain side. How do you wrap all that up into a 30-second, this is how we're going to end the consult?
The first one?
So
I will have had a crack at trying to make your adductors feel better. I'm not going to rub them. You fucking rub them yourself, but I'll have a go.
I'm disappointed, especially that I'm not face down on your bed. I'm already upset.
I'm gonna try and do something else movement-ish to try and see if that will change it, or at least show you that you can do it. I'm gonna focus on what you can do. So I'll do a lot of assessment stuff and reassess it and see if I can show you that, or where to start, and show you why it's safe. And then I'm going to go, this is what I think it is, and this is a guideline in terms of what we're going to do. This is what we're going to do next. This is what you can do. So of what you told me was important to you, this is the amount that I think you can tolerate. If I'm going to give you sort of best and worst case scenario. So if it's amazing, then you can also go and do that. If it's shit house, which it could be, then we're going to pull back and only do this. Balance of probability is it'll still be there, but hopefully you start to notice it improve as you do more. If you're unsure of that, you let me know and we can troubleshoot that in between. And then what we'll do from next time, we'll do this, and then we're going to go here from there. How does that sound? And I always end with a question in terms of, does that sound okay to you? What do you think about that plan? Blah, 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 blah.
My actual experience was I saw a clinician who did an assessment, did some manual therapy, seemed to help. And I got the, we'll see how you go in 4 weeks. So that's what actually happened to me. And it's just interesting. I still don't know what to make of it in a sense, but probably shows not to say, we'll see how you go. And maybe because I was a physio and this person knew I was a physio, that always has some kind of interaction. What was strange is like, and these might be, I've found that for this particular injury, manual therapy seems to help, but it also seems to push out the onset of my pain. So weeks where I haven't had manual therapy, it seems to come back in 2 or 3 days. And weeks where I do get manual therapy, it seems to go to 5 to 7 days, which is really weird. There's a lot of complex variables in that. Who knows what I've done in those 2 or 3 days or those 5 to 7 days? And also I think about my preference. Being a physio is my preference that some form of manual therapy might help. And when I don't get it, this happens to me. So in that, there's a lot of pearls for young therapists that preferences can make a huge difference too.
Yeah.
And it's not the manual therapy.
Meaning.
Yeah, the meaning.
It's the meaning of it. Yeah. So like that's part of what, like there's meaning attached to symptoms, good or bad, and then there's meaning attached to interventions and the effect of those things too. So, and you're the only one that can determine that. So I think that's important. I make a decision around what I do and don't do. And again, that's I touch it. I would jam my elbow into your adductors until you cried. But rubbing them for 20 minutes, probably not. So I don't tell people that I do that either. Like I don't market to people to say, come here and feel all better and cushy and I'll give you a cuddle. I don't say, that's not what I do, you know? So this is where I think a lot of the confusion or problem arises, is that maybe clinics say, yeah, everyone come here, but then they go, oh, by the way, but we don't do that. And that's bullshit, right? So if someone can choose, if they really, from my point of view, if they're really informed about what things can and can't do, and they want it, who the fuck am I to say they can't? I don't have to do it if I don't want to do it. I can't tell them though that I can't expect them to pay for what I want to give them if they don't want it. That's bullshit, right? So but it is, and I don't think we're ever going to be able to explain your experience with that. I don't know. I don't think we'll ever know that. But that doesn't mean it's not a valid thing if that's your experience of it. And if you want a week where it feels better compared to 2 days, great. Like of course you can do that. Why could you not do that?
I think inherently what I'm seeing is potentially you may be taking that opportunity away from a patient if you're leaning to one end of the spectrum or the other. And when we see the division online, what comes up for me is potentially, are young physios taking away an opportunity for a patient to feel a certain way or preference a treatment that might help them? And within that is a power dynamic too, of like, even I would be embarrassed to ask a physio, can you do that thing on my adductors because it helps? I'm not sure how many patients would actually kind of say that. So we can kind of pretend that, well, the patients would tell us. I'm not sure they would. I'm not sure I did. Like, I would be kind of embarrassed to say, shit, like I kind of know the way out of this is X, Y, and Z, but that thing really helped. And there's a bit of a power dynamic there that came up for me of like, I'm not sure I'm going to ask that because it's a little bit embarrassing, but the opportunity's been taken away.
Yeah. I think also too that and again, when I say expert, I put my tongue firmly in my cheek, but where I have gone through all of these different iterations of what to do. So when I land on what I'm doing, I have a pretty decent reason to land there. I think how do you know that you can't or shouldn't or wouldn't do it if you don't see? Like that's what I don't really get. Like when you and I'm going to sound really old and stupid here, but when you haven't had much life experience and you're so adamant that some things are bad, how do you know that? Like how do you know? So unless you've been treated extensively yourself, or you haven't been treating extensively. So I just don't know how you have these strong opinions about stuff that you couldn't possibly understand from any point of view.
I guess your decisions happen afterwards is what lands for me. All of your decisions and great questions and A, B, C scenarios happens after you've done manual therapy in your way and your version of it. So now you're more confident. Maybe what you're landing on at the end there is if you don't give yourself the opportunity to that, well, now you're landed in your bias and you actually haven't given the opportunity to the patient either.
Yeah.
And that's probably what I'm seeing, to be honest. That's what I'm seeing from young physios who may be abandoning manual therapy. And then it's like, have you taken away that opportunity? And do you really believe the patient's going to ask for it if you haven't done like a cheeky little thing like you do, where while they're up doing an assessment, you've actually poked and prodded something?
Yeah, I mean, I just it's at a point now where I'm like what's the big deal if you push on someone's. I'm interested in what you're telling people, whether you do it or not. I don't even give a shit. But the thing that hurts people is what comes out of your mouth. Even if I did rub your adductor for 20 minutes, like, so what, So it's, if I'm telling you that if I don't do this, your leg will fall off. That's what I'm interested in. So, so I am with it at the moment. I'm just like, look, just there's bigger things to be talking about, I think, in terms of where problems arise for patients. I think a lot of it, this is about clinicians. It's not about patients anymore,
I like it. Let's leave it there, mate, because you got to go soon, and that's a nice 30 minutes, I think.
Rock and roll.
Thank you, mate. We'll do a part 2. There's more to talk about.
Yeah, awesome. Sounds good. Thanks, man.